la quarta edizione del Congresso Internazionale sul RAI. E per noi è un grande onore dare il via a questa nuova edizione, che anche quest'anno vede la partecipazione di numerosi esperti, clinici, ricercatori, professionisti sanitari e aziende provenienti da tutta Italia e dall'estero. Il nostro congresso nasce con l'obiettivo di offrire un momento di confronto scientifico e aggiornamento multidisciplinare, mettendo al centro la patologia oculare che coinvolge in misura sempre crescente la popolazione e che richiede un approccio sempre più integrato, ossia la sindrome dell'occhio secco. In questi anni abbiamo assistito a una profonda evoluzione nella comprensione del trattamento del dramma, grazie al progresso scientifico, tecnologico e all'incessante lavoro clinico sul campo. E proprio per valorizzare questi progressi e per continuare a costruire una rete di conoscenze condivise, oggi siamo qui. Un sentito ringraziamento va ai relatori per la qualità, la disponibilità e il valore dei loro contributi scientifici, alle aziende partner per il sostegno e la fiducia dimostrata nel nostro progetto, a tutti i partecipanti per la vostra presenza attiva, la curiosità e il desiderio di crescere insieme, e in modo particolare agli enti e alle società scientifiche che hanno concesso il loro patrocinio, riconoscendo l'importanza di questo appuntamento per la formazione e l'aggiornamento continuo del nostro supporto e per noi motivo di orgoglio e conferma il valore scientifico e culturale di questo congresso. Nei prossimi giorni parleremo di diagnosi avanzate, nuove frontiere terapeutiche, implicazioni sistemiche e delle innovazioni che stanno trasformando la gestione del DRAI, con un'attenzione particolare alla personalizzazione del trattamento e alla qualità di vita dei pazienti. Vi auguriamo 3 giornate ricche di contenuti, confronti, ispirazione e perché no anche di nuove collaborazioni. Dichiariamo ufficialmente aperta la quarta edizione del Congresso Internazionale sul DRAI. Grazie a tutti e buon lavoro. Iniziamo la prima sessione con la professoressa Caterina Gagliano. Grazie.
Ringrazio per l'invito. Ovviamente che ogni anno veramente si riempie di entusiasmo perché ci si rivolge a un mondo, veramente un universo che è quello dell'occhio secco, che non deve essere assolutamente visto come un singolo approccio al nostro organo, all'apparato oftalico, ma sicuramente si estende anche ad altro. E non a caso parliamo oggi di sindromi sistemiche, di malattie immunitarie, di malattie immunologiche che coinvolgono tutto il nostro organismo e che vedono l'occhio non solo spettatore, ma che entra nel determinismo della peggiore situazione in cui si può trovare un paziente che soffre di una malattia oculare. Parliamo della sindrome di Sjögren, ma sicuramente non parliamo soltanto di questa, parleremo anche di tante altre cose. Qui vedete numerosissimi loghi che vanno dalla mia università anche a un centro clinico diagnostico che accoglie un centro per le malattie immunologiche e per le malattie rare, che oggi lavora tanto su questi aspetti, e inoltre vedete anche un gruppo di ricerca, un gruppo di giovani che si vede attivo nell'ambito dell'innovazione, nell'ambito della ricerca, soprattutto di tipo interdisciplinare. Questo è il motivo per cui ho mostrato questi loghi. Bene, parliamo. Bello questo. Ma allora, su cosa vogliamo porre l'attenzione? Vogliamo porre l'attenzione su qual è realmente il ruolo dell'oftalmologo in un contesto di una malattia sistemica. La sindrome di Sjögren, voi sapete, secchezza oculare, secchezza delle fauci, ma non solo, abbiamo un coinvolgimento di una serie di elementi glandolari che riguardano tutto il nostro organismo, che vanno dalle ghiandole sudoeripara e altri tipi glandolari. Quindi non ci soffermiamo come di solito viene fatto sulla ghiandola lacrimale principale. Cercheremo di ampliare lo spazio su tutte le altre cose e cercheremo di capire quando è il momento di approcciare il problema del paziente dal punto di vista sistemico, quando il problema invece si può affrontare esclusivamente nell'ambito della nostra branca. Va bene. Due note epidemiologiche purtroppo non si vedono qui, però vi posso dire che è una malattia a tantissima incidenza nel sesso femminile, è una malattia in incremento notevole in questo periodo. Noi vediamo i nostri reparti ricolmi di patologie immunitarie, patologie infiammatorie, e la previsione del futuro sarà sempre di un incremento, quindi è un problema che dobbiamo sicuramente approcciare. E qual è il coinvolgimento? Non solo il coinvolgimento oculare, ma il coinvolgimento del sistema nervoso centrale, del polmone, i linfonodi, sono i reni, cioè sono delle patologie veramente invalidanti e pongono anche la necessità di fare una diagnosi differenziale con una serie di problematiche, considerando che si presentano con un aspetto variegato. E qui vedete il coinvolgimento articolare, vedete come si possa verificare nell'ambito di questa patologia una neuropatia, quindi il paziente che lamenta una problematica di dolori. Ma vediamo che cosa fanno i nostri colleghi reumatologi e come noi possiamo interagire con loro. Intanto l'EULAR, che è una grande associazione che si occupa delle problematiche reumatologiche e serve proprio ad individuare quelle linee guida che poi ci fanno capire quando il problema sia importante, quando sia grave, quando deve essere approcciato solo da noi o quando deve essere curato con una terapia sistemica. Bene, c'è uno score che viene esaminato e qui praticamente dobbiamo cercare di puntualizzare le nostre conoscenze, cercarle di far conoscere anche agli altri colleghi, perché ancora oggi qui nelle linee guida dettate dall'EULAR si parla di Schirmer test. Bene, lo Schirmer test è un validissimo test quando non si ha nulla a disposizione, ma sicuramente noi abbiamo altre conoscenze oggi che ci fanno capire che la sindrome del dry eye, soprattutto in una patologia di questo genere, non interessa soltanto la componente acquosa delle lacrime, quale viene indicata appunto dal test di Schirmer, ma interessa anche le altre componenti, e le altre componenti ghiandolari, che siano le ghiandole di mebonio con la componente lipidica, che siano le ghiandole le cellule che producono mucina, sono tutte quante interessate da un problema di grande infiammazione, una grande infiammazione che sicuramente deve essere combattuta anche dal punto di vista sistemico. È una malattia a lungo termine dove, se non c'è l'interazione anche col medico di base, se non andiamo a puntare l'attenzione su tutto quello che viene fatto sul paziente, ahimè avremo problemi ben gravi, e questi problemi ben gravi si possono ripercuotere, vedete qui, in forme infiammatorie molto importanti, che se non curate possono andare a perforazione della cornea, a coinvolgimenti veramente importanti. Ricordiamoci, ben il 70% delle forme infiammatorie in questo genere di patologie, ma non solo, diventa grave se non trattata, e la gravità si manifesta anche con perdita del bulbo oculare, non scherziamo. Quando il fenomeno del dry eye viene considerato un fenomeno di massa, bene o male tutti ce li abbiamo, cerchiamo di approcciarlo in maniera seria invece. Noi qui siamo oggi tutti quanti sensibili a queste problematiche, ma se ci costituisce la palpebra, perché l'infiammazione può determinare una nuova entità nosologica che possiamo interpretare. Quando noi andiamo a vedere delle alterazioni sulla superficie corneale, ricordiamoci che queste possono derivare da un'infiammazione della palpebra, dalla congiuntiva tarsale, che essendo proprio il posto della flogosite assoluta, strofinando continuamente sulla superficie corneale, dà dei fenomeni infiammatori e dei fenomeni di deficit cellulare. Questi fenomeni noi pensiamo talvolta che sono a partenza soltanto della cornea perché è disidratata e non guardiamo le palpebre, però se noi stiamo attenti ci sono delle caratteristiche delle caratteristiche che determinano proprio una nuova entità nosologica che è una keratopatia bleibomite correlata, che è dovuta proprio a queste lesioni epiteliali granulari. Guardate, se vediamo con attenzione, noi le possiamo osservare in maniera dettagliata quando andiamo ad osservare la cornea con una colorazione particolare. Queste sono tutte ovviamente le diagnosi che noi possiamo fare con i vari metodi diagnostici, ma guardate qui, vedete l'alternarsi di questi puntini colorati a dei puntini bianchi, che sono appunto delle condizioni particolari, le dark spot adiacenti, possono essere l'indice di un'infiammazione che proviene appunto dalle palpebre, e nei soggetti con sindrome di scia appunto questa è una condizione che si verifica frequentemente. Bene, se noi vogliamo andare invece ad affrontare l'ambito della terapia di questi pazienti, non dimentichiamoci che una terapia topica deve avvalersi dei diversi componenti delle lacrime, non basta il solito acido ialuronico, non basta sicuramente sopperire la componente acquosa, ma dobbiamo trattare in maniera completa e in generale con un atteggiamento multidisciplinare, non possiamo avvalerci solo del nostro. Infatti, con le recenti conoscenze non facciamo altro che cominciare a delle nuove terapie che prevedono anche l'uso dei biologici. I biologici sono difficili sicuramente da gestire, non possiamo gestirli soltanto noi, ma sicuramente ciò andrà a dare al paziente una nuova vita veramente, perché il paziente che presenta una problematica veramente così grave sicuramente non può essere trattato soltanto con il semplice trattamento topico. E nell'ambito del trattamento topico non dimentichiamoci che non dobbiamo vederci solo di collini, ma dobbiamo andare a presidi di secondo livello e di terzo livello, cioè a vederci di sostituti di medici in genere linguento e non solo, anche di sostanze e di molecole importanti. Intendo dire, quando c'è da fare ricorso alla ciclosporina topica si deve fare, quando c'è da fare ricorso all'atronicus si deve fare. Tutto questo ovviamente presuppone anche dei piani terapeutici, delle difficoltà prescrittive che se volete magari in un'altra sede affrontiamo anche questa problematica, però non dobbiamo dimenticare che il paziente spesso ha bisogno di questo e se non c'è sono veramente condizioni veramente severe. Bene, grazie per questo, la passiamo a passare alla seconda. Sempre parlando di condizioni sistemiche, perché questo dobbiamo fare oggi quando appunto il gruppo di ricerca
tutto, azienda, tutto.
Si occupa di ricerca interdisciplinare. E il secondo argomento della mia
Quindi io faccio le foto davanti alla mia telecamera, tutti stanno parlando, ci sono 2000 oculisti attaccati, quindi faccio le foto e le metto così, se piate l'anderculo, capito?
Abbiamo conoscenze che sempre si affacciano con una funzionalità.
Sì, tutto contrattualizzato, anche le aziende. Allora, aspetta, c'è mia figlia che sta parcheggiando, non trova.
Dell'occhio veramente come un universo senza limiti. E guardate che cosa non si produce nell'ambito dell'argomento microbiota, ne parlano tutti oggi, cioè in tutte le patologie, in tutti gli organi, eccetera. L'incremento esponenziale delle pubblicazioni scientifiche in tal senso è veramente stupefacente. E guardate, però quando ci si chiede ma che cos'è il microbiota? Cioè, altre volte si è increduli, esiste, non esiste, dove si trova, come lo localizziamo, ma cos'è un organo, è un tessuto, oppure nulla di tutto questo. Siamo di fronte ad uno sconvolgimento di quello che è l'approccio con il microbiota, perché oggi il microbiota, così come Cartesio per la sua intuizione localizzava nello spazio e nel tempo tramite due lettere, noi lo dobbiamo in qualche modo identificare in un modo particolare. Ma questa identità del microbiota probabilmente non la vediamo tanto nella presenza del microbiota microbiota intestinale, punto, ma dobbiamo cercare di capire che si trova, se troviamo la slide giusta, che il microbiota si può trovare in ogni luogo. Per cui lo troviamo a livello della superficie oculare, ma anche della superficie del derma, lo troviamo a livello dell'apparato faringeo, lo troviamo persino nel sistema nervoso centrale. E quindi allora come ci si regola? Se occupa uno spazio, se non occupa, se ha una forma, come rispondiamo a questi quesiti? Probabilmente possiamo rispondere così, che il microbiota non è un organo, non è un apparato, ma è un sistema. E quando si parla di sistema, cosa ci ricorda per esempio il sistema linfatico connesso, con una connessione con un organo insieme all'altro, con la possibilità di interazione, di dialogo, di cross-talk tra un sito rispetto a un altro. E tutto questo viene anche a dialogare con il nostro sistema immunitario. Quindi pensate all'importanza che assume questo genere questo nuovo approccio, diciamo, col microbiota, che anche quello è un argomento che poi viene considerato relativamente importante, perché è alla portata di tutti, perché tutti sappiamo che se noi abbiamo una disbiosi intestinale, tutto questo si riflette in un comportamento differente anche a livello dell'alimentazione, anche a livello di tutto quello che può comportare il nostro comportamento e la nostra salute. Questo lo sappiamo. E a livello oculare anche lì abbiamo il manifestarsi di una serie di patologie che vanno poi ad identificare una sindrome infiammatoria caratterizzata dal calore, dal rossore, dal dolore, dalla funzione compromessa. E che cosa dire anche dell'atteggiamento psicologico che una persona ha nei confronti di una patologia che sconvolge il suo comportamento? Questo è un tentativo di medicina narrativa che talvolta mi viene comodo utilizzare, perché ci fa capire realmente qual è la compromissione anche psicologica del soggetto, del paziente. Questa è una donna che parla di un paesaggio che vede come doloroso e amaro, quando l'infiammazione raggiunge i gradi elevati e la necessità di rinunciare a tantissime cose, che vede proprio come una mutilazione, anche quella di non potersi truccare, per esempio, e il fastidio e il dolore che identifica come cose perenni. Bene, tutte queste definizioni, queste informazioni che il paziente ci dà, quando noi abbiamo una compromissione del microbiota, assumono un valore veramente esteso a tutto l'organismo. E cosa vuol dire il microbiota a livello della superficie oculare? Vuol dire una barriera anatomo-microbiologica costituita dal microbiota, dallo strato lipidico, mucinico e del vitello, e se una barriera competente, allora abbiamo la possibilità di difenderci da quello che è il mondo esterno. Se invece una barriera incompetente, abbiamo quella forma che a livello intestinale viene definita la perdita del liquido, perdita della possibilità di interagire con tutto quello che viene fuori. Ma che cos'è in realtà il microbiota? Come lo distinguiamo? Il microbioma è la parte genetica, una parte genetica che viene ereditata e che quindi non si può modificare, ma tutto quello che sta attorno, quello sì, si può modificare e dipende dall'interazione con il mondo esterno, dall'interazione con il nostro sistema immunitario. Quindi è una parte di noi, è fortemente condizionante la nostra vita e ne abbiamo un beneficio reciproco. Se noi viviamo perché i nostri germi funzionano bene, i nostri germi funzionano bene perché noi viviamo, gli forniamo delle sostanze utili anche. E che cosa succede? Questo è un condizionamento che abbiamo sin dalla nascita, quindi è differente il microbiota che di un bambino che nasce con parto naturale rispetto ad uno che nasce con un parto cesareo. È differente anche nei momenti in cui il bambino si approccia al mondo esterno, per cui se subisce degli eventi stressanti il suo microbiota si altera e tutto ciò avrà un effetto anche nel futuro. Ma cosa dire in quel momento della nascita, del passaggio del canale del parto? Alla nascita noi cerchiamo in qualsiasi modo di pulire il bambino, però creando anche un danno, perché depauperare il suo microbiota alla nascita significa fare proprio un danno, considerando il beneficio che questo può causare. Qui vedete rappresentati tutti gli organi, in particolare sappiamo bene che il microbiota intestinale ha la sua importanza fondamentale. Perché è importante? Perché in una condizione in cui nella mucosa intestinale perde, noi abbiamo l'assorbimento di numerosissime sostanze pro-infiammatorie, vedete qui shock proteins, che assorbendosi a livello sistemico vengono poi eliminate anche a livello delle ghiandole di mecomio, determinandone una infiammazione importante. Tutte queste condizioni portano poi ad una situazione di infiammazione a livello della superficie oculare, non solo quindi quando, come osservavamo poco fa, un'infiammazione delle ghiandole, ma anche della componente palpebrale. E noi sottolineiamo l'importanza che in una condizione di dismetabolismo intestinale, di disbiosi intestinale, noi abbiamo la produzione di un occhio secco con particolari caratteristiche che sono l'alterazione della componente lipidica, quindi non solo una disfunzione lipidica perché si perdono i lipidi utili, ma perché diventano inefficaci, diventano talvolta anche tossici i lipidi eliminati dalle ghiandole di mecomio. E poi tutte quelle problematiche che noi, grazie a Dio, affrontiamo con tutte le metodiche, non solo terapeutiche, ma fisiche e parafisiche, che vedete illustrate sicuramente nel corso di questo congresso. E non sia una componente immunitaria anche a livello normale, pensando che l'occhio è un organo isolato, risponde bene, e come il sistema immunitario dialoga con il nostro microbiota, sicuramente in questa slide ne vedete alcune caratteristiche, di certo non ci possiamo soffermare a descriverle tutte, ma sicuramente fiumera primaria dovute a cosmetici o alterazioni dovute ad altri fattori, come per esempio l'uso dei videoterminali. Anche lì abbiamo una condizione che determina un circolo vizioso, perché l'uso del computer, ovviamente di cui nessuno può farne a meno, determina però delle alterazioni poi della componente lipidica. Se queste si associano ad un'alterazione infiammatoria legata a una disbiosi intestinale, sicuramente tutto questo andrà a determinare una grave modifica della secrezione periodontiana. Qui vedete alcuni cenni a tutto quello che si è pubblicato in questi ultimi periodi e vedete anche un cenno a quello che può essere una nuova strategia terapeutica che si può avvalere di probiotici, batterioterapia o approccio nutrizionale integrato, ma sicuramente sarà diverso rispetto a quello che noi pensavamo un tempo, ma probabilmente ci rifacciamo anche a quello che è stato nei tempi molto antichi. Grazie.
Grazie Caterina, è interessantissimo sapere che c'è questa correlazione tra il microbiota intestinale e l'occhio secco e quindi l'importanza della dieta, cosa di cui ci parlerà anche più avanti nella prossima sessione del dottorio su questo, che è un argomento secondo me molto importante. Adesso parlerà invece la dottoressa Sandra Venturter di un argomento complesso perché parla di microimmunologia e proteomica nell'occhio secco. Prego.
Sì. Esatto, a nightmare topic, ok? Intanto grazie dell'invito, è un onore essere qui, è un piacere. Allora. Okay, so as I told before, it's always the topic that makes a bit of, how do you say, worries, because who remembers really well all what we studied in university? Over the last decades, the tear film has become an important tool to study not only for ophthalmologists but for many other medical topics, what we can find. So we can use it to determine a series of patterns, like certain constellations that are linked to determinate pathologies. For instance, we can now detect a pattern as a risk factor for glaucoma simply using the tear film, which is easy to obtain and an excellent way to analyze. So another pattern which is very interesting is, as we look at the S100 calcium binding protein A8 and A9, we know that they are linked to the severity of the meibomian gland dysfunction. And as Professor Galliani just told us, the rheumatic diseases are often linked to the whole body. Like we often see involving all the structures of our body. It's not a localized pathology. And so what is easily addressed in the first stage is the innate immune response. So what we see is an activation of the cellular innate response, which acts right away. So if this gets, if it finds a resolution, it's all okay, but we might have the contribution of generalized T cells and B cells, which might have an adjunct worsening of the pathology, and we see that there are not only the usual T cells, but we find autoreactive T cells who worsen the whole situation. So, who are the T cells? Well, they make part of our immune response, and now we're looking especially at him, at the helper T cell. Who is he? What is he doing? He's actually doing a great job by producing cytokines. So he's not directly addressing plasma cells, but he does this by the production of cytokines who will pass the message. So the T cell, the T helper cell, is very important for the production, the recognition of antigens and the production of antibodies. But it's also very important for the activation of the cytotoxic T cells. So here again you see, this is the part that we're now looking at. The T cell mediated immune response. That's it? I don't know. Stopped? Yes, it stopped. Okay. So the T cells, which are lymphocytes, of course. Can you just, mi puoi aiutare che non va avanti per piacere, si è bloccato? Sotto? Okay. So the T cells, which are, okay. Which I would like to talk about, the most important one, lo stesso. C'è un altro modo per come mandarlo avanti o solo questo?
Ok?
Non so, c'è un punto dove... Alright, so the T helper 1 and T helper 2 cells. So in usual conditions we have a balance between the T1 population and T2 population. The cellular reaction is what does T helper 1, and the T helper 2 is involved in the antibody reaction. So in case of a pathology, what do we see? We see a disbalance, and we not only have a big amount of the Th1 helper wing, but we also have the production of two other T cells, which are Tregs, which are very important for the regulation. They're very important in kind of a cancer situation to create the tolerance, an immune tolerance. But we also have T helper 17, which is very important for the dry eye because they are the helper cells who produce interleukin 17, which we know is very important. Interleukin 17 is a group of interleukins which will promote chronic inflammation. But which is very important to understand is that there is a regulation, that there is a balance between the two arms. T helper 1 and T helper 2, they do control each other. It's a reciprocal control. You see, interferon gamma does down-regulate interleukin 4, which is the top interleukin produced by the T helper 2 arm. And on the other hand, you see how interleukin 4 controls, down-regulates the production of interferon gamma. So this is actually what it is. It's the balance. And if you think well about it, we're not talking about micrograms, we're talking about femtograms. So it's a concentration, a very low concentration of cytokines, hormones, and neuropeptides that move between a certain range. If we get over or under this range, that the balance is going to one side or to the other, then we can find a situation of dysregulation, or so to speak, pathology. So, this is what happens in an early inflammation. IL-1, this is like the first line interleukin which is produced in the early inflammation situation. Then we have IL-6, this is the interleukin for the aging, for the fibrosis, chronic inflammation. We have then interleukin 17, as I just told you, very important for the dry eye situation. On the other hand, the big calmers, the big players on the other hand are interleukin 4, which downscale inflammation. We have interleukin 10, and then we have, of course, the tissue growth factor beta, which is the great reconstructor. He reconstructs the tissue. But they're not the bad guys or the good guys for excellence. Like, everybody has its role. For example, interleukin 17, okay, is dangerous for our dry eye situation, but interleukin 17 is crucial for extracellular bacteria, fungi recognition. So if we have a dermatomycosis, we often have a lack of the interleukin 17 in those patients. So it is vital in those situations. So let's come back to the balance thing. It would be ideal if we only could correct those disbalance by giving the right agonist or antagonist in order to recreate balance, wouldn't it? And actually, there is an all-Italian approach to this. This is the PRM, which is a hybrid of the molecular biology, the PNE, the psychoneuroendocrino immunology, and the low doses medicine, because the doses has to be very slow. In this field, in this approach, we use medicines of a very low dosage, which is the same concentration that is present in the extracellular matrix of the human body. So, how can this work? This does work. Also thanks to the sequential kinetic activation, which is a very, very special drug delivery system. And I hope you all feel a little bit of curiosity about this. Thank you.
Grazie per la interessantissima relazione. L'esaminatorio, system treatment, and your operating place.
Very good. Hello, everyone. It's an honor to be here and also to be with all of you. Thank you for my host. I'm going to do my best to avoid the gongs, so let's jump in. surface. We are going to be looking at the interventions that can interfere with our patient's healthy ocular surface. So some of you may have aesthetic practices along with dry eye practices as we do, some of you may not. My purpose today is to make you aware of interventions that your patients may be participating in as a result of accelerated aging due to periocular inflammation and the rosacea that goes along with dry eye. I'm going to get this right in just a second. How about not to be in? It's got a mind of its own. Okay. Okay, here we go. Our goal is to align what our patients want. They want aesthetic outcomes. What we want is ocular surface health, and we like not to compromise that. The ocular surface is unique. It is very thin. It is the thinnest skin of the body, in fact, just a few millimeters on the lower lid. That means that products and treatments that go there are going to be rapidly absorbed and affect other structures like meibomian glands, obviously the ocular surface, even the lacrimal glands. It's going to show the age more quickly. This is important for, again, our dry eye patients and people with rosacea. Okay, ocular surface complications, many things can happen, not only with these artificial lashes that are very popular in the U.S., dry eye, meibomian gland dysfunction, SPK can be developed, contact dermatitis and allergic reactions, even erosions related to the glue of these particular products, and with Botox applied in and around for crow's feet and the periocular area can interfere with the blink reflex and cause mild ophthalmos. Skincare products, you have to be very careful in dry eye patients. You want to avoid all acids that could cause a flare and rosacea. That means glycolics, that means salicylic acids, retinoic, and even ascorbic acid that's not in ester form. And then, of course, we know that topical prostaglandins that can cause lash and brow growth can also cause meibomian gland dysfunction. There are interventions and treatments that are better than others. This can be a bit of a mixed bag. Botox, as I mentioned before, can interfere with the blink reflex and the expression of natural meibum on the surface of the eye. Fillers can lead to lid malpositions. Chemical peels, obviously, you have to be careful with the ocular surface. IPL hits a very nice sweet spot. And there are many, many energy devices. I'm sure we'll hear more about through this talk. But one of the ones that we found to be particularly effective after IPL is a CO2 laser, in which we can use heat and light beams to get out into the skin and create a longer resolution of the rosacea along the lines of about 5 years. And so what you're seeing there is a patient that had one treatment. Blepharoplasty obviously is going to cause at least a short-term problem with the ocular surface. There are providers that are doing blepharoplasty that don't have the skills and knowledge about the structure and function of the eye as we do. Here is one of those patients. We specialize in revisions at Toya's clinic, and you can see here that many things have gone wrong. The ptosis, there's an absence of the angle. This patient is definitely exposed to light ophthalmos and eyelid malposition with a exacerbation of her dry eyes. The best practice is for us to be aware as eye care providers that our patients may be seeking these treatments, that they may be seeking them for people that don't have the awareness and the knowledge of ocular surface disease or dry eye, and ideally the ones that do have the knowledge, us, the people that are sitting in the room, we're providing both to give ideal outcomes. Thank you so much.
Permettetemi di ringraziare il dottor Tedesco per questo invito e per aver unito persone di ogni dove, specialisti nell'occhio secco. Io sono una reumatologa pediatra e so quanto è importante una diagnosi precoce una diagnosi precoce di occhio secco in un bambino che può essere la spia di patologie reumatologiche più importanti come l'artrite. Ma non voglio togliere altro tempo, per cui vi presento chi ne parlerà a lungo di occhio secco, la professoressa Domenica Tremontina, che parla appunto di occhio secco pediatrico. Grazie.
Buongiorno a tutti e grazie mille per l'invito a Giovanni. So I'm so sorry, but I will refer with English and just will talk about pediatric dry eye. So I try to do my best with this very nice device and to go, I don't know if it will work in this or this. Se è possibile fare un video avanti. Thank you very much. Okay, so pediatric dry eye. And so pediatric dry eye, we know about the common disease in adults, of course. And the prevalence for children is it's a very strange prevalence. But we have recently meta-analysis, and in the pediatric population, it has been around 24%, which is a lot, I think. So usually it's missed or underdiagnosed for the children, like a simple chronic conjunctivitis worsened by screen use. And also the most common is posterior blepharitis with mammalian gland dysfunction, and it may cause dry eye. There is also, and thank you Melissa for the skin disease, because dermatologic pathology are also involved in children. So we all know about eyelid anatomy with the rows of eyelashes and mammalian glands. But I don't know if you know about when it goes. This is from fetus, and you can see it's very early. You can find like the goblet cells just going. Just red eye, just itching or tearing or secretions. But how to diagnose exactly? Because usually the parents say, okay, that's okay, go back, it's all right. And in dry diagnosis, we have two different diagnoses to do. There is very severe forms, and they are easy diagnosis because it's systemic disease, like severe apoptosis, Lyell syndrome, GVH, ectodermal dysplasia, Sjögren's syndrome. But there is also moderate forms that could be more accurate, commonly underdiagnosed. However, they can be very disabling for children. So like ocular allergy, blepharitis, or mammalian gland disease. Well, we just published a Delphi study with to reach expert consensus with pediatric dry eye disease and adapt adult definitions for the pediatric use, because it's not the same. It's not, children are not a miniature adults. So we had to identify specific needs in pediatric or family care. And so it was a study overview. I will not detail exactly what we did, but there was 42 European pediatric ophthalmologists invited, with 6 scientific experts with a questionnaire, and a high participation for 80% trial. And so you have here the child study overview, and you see the consensus for some and not for the others. And so one point is, you see there's a lot, you can read it if you want, but what is important is evaporative is much more common than aqueous deficiency in children. And also the point is assessment tools. And also VX is insufficient for children. And also other threshold diagnosis is probably much more different. And I will show you that. Because there is assessment tools like HG panels, like normative pediatric data, diagnosis tools, and challenging using the adult thresholds. And so just to show you, one point is tear film examination. So schema test, fluorescein, but the breakup time in children, do you know if it's exactly the same in adults or it's different? What do you think? No thinking? Okay, that's all right. Okay, they are absolutely different. They are very important. So it means that if you just would like, it's abnormal when it's less than 15 seconds. So keratitis. So very severe forms that are diagnosed by systemic disease. So we have severe keratitis, Lyell syndrome, ectodermal dysplasia, Sjögren's syndrome, and I will show you very quickly some cases. Of course, when you see here, dry eye syndrome is very easy to diagnose. And this is also very difficult to cure. It's difficult because it's so dry, there is so lack of mammalian glands, so that's a very, very difficult time. and severe ptosis here, and here Lyme syndrome. This is crazy that we see in my hospital. But let's go to moderate forms and disillusion for children. So there is no more on the screen if there is any problem. So, granular conjunctivitis with toxic forms, with giant papillae, also with liberal form, with transverse dots here, and would be also much more important than you can see here. But what has changed for the children? What has changed, of course? Screens, light, outdoor light, nutrition, and myopia. You know all about pandemic myopia. And so you can see the young child, he was just at the entrance of the hospital during 20 minutes. I didn't see the parents, so that's why it's crazy. Oh, good, thank you. So we can go and just go back to the dysfunction here to have mammography, to go scan. We know about TIOLAB, not so easy to do it in children, but we did a very small study. And this is interesting also because the cutoff for the lacrimal osmolarity in children is not the same. And so you can see here, it's higher. And ocular surface in children is really highly affected. So you can see all of these complete blinking here and SPK. And this is a courtesy of adenolactory for MP mapping. And so you can see here the difference in numerokeratitis with this stromal infiltrates. So we don't know exactly how is the ocular surface in children after those keratitis or conjunctivitis. And so, important also, recurrent chalasia in children. Itching, redness, secretion, but recurrent chalasia, it's a very common situation. And it's more than this. And you can identify the blepharitis and grading for the posterior blepharitis until the recurrent chalasia, but it's not always. And it's just some minutes more. Dermatitis is unusual in children. And but we have severe ocular rosacea in children here, and when you see the very high specific sign with itinerant keratoconjunctivitis. And so you have to treat, you have to go to the dermatologic examination also. And so we did the Delphi also with the treatment. So you have here topical steroids should be avoided as possible. And we have also requirement for the treatment strategy. Everybody knows about this T-Force juice and also about the more common clinical evaluation for the visual circle. And so in children, MGD plays a real major role in those age groups, and symptoms are really underreported. So conclusion, pediatric dry eye has specific characteristics. So multifactorial and chronic, and there is a need for an appropriate diagnosis, importance of multidisciplinary and parental input, limitation for this study, but we need more guidelines, and so be aware of potential risk treatment with steroids. And so thank you very much for your attention. Merci pour votre attention. And thank you for
domande?
Thank you, very nice to know. Can I add one comment and one question? Is that all right? Great, look. So what I'll say, you mentioned nicely that the secret upfront is higher, the risk is higher actually, and the osmolarity is also higher threshold. I can add something about legal acrophthalmos. They have physiological legal acrophthalmos. They don't need to add as much as adults, but they're still resilient. So a person is very resilient to children. Now the problem is, with this compromise, there will be an increase in the disease. So my question to you about the role of anxiety and stress, which is in other people more than in children, and we see most of the problems with various other mental health issues, they are straight dry disease, and they cannot control more than some of the child in the clinic.
Yes, I agree for sure. I agree. I did not take that because it's also a very short time, but for sure, they blink less. But usually they blink less because the overall surface and material film is pleasure, so they don't need to blink so much. But of course, if there is any disease, it's a problem. And for the stress, of course, there is a problem too. And you see also dry eye just growing with myopia too. So I think this is a whole bunch of problems, and I agree. Thank you for this question.
Ok, vabbè, ci penso io. No, la taglio, poi ci penso io, lo sposto.
Viene utilizzata ancora la tecnica della costruzione dei buchi lacrimali deliziosi.
Veramente una cosa molto importante da sottolineare. In tutti i pazienti che hanno una malattia del sistema, talvolta la concentrazione di citochine peritraumatorie nelle lacrime è molto elevata. Chiudere il continuo primale si può significare far risiedere per maggior tempo sostanze pro-infiammatorie sulla superficie della e quindi determinare tra i provvedimenti. E poi non dimentichiamo anche un'altra cosa, che nell'ambito delle forme io ho sottolineato l'importanza della florosi contemporanea. La florosi del vettore primale del continuo lacrimale è spessissimo presente nel paziente con sintomatologia con una patologia infiammatoria. Quindi attenzione, se noi posizioniamo un dispositivo di questo genere che viene, io lo utilizzo perché ma in condizioni sicuramente diverse, non in queste.
Io do due domande. Una sulla SIOP è sufficiente fare ecografia delle gambe salivali o per forza biopsia dobbiamo fare?
Questa è una domanda che ringrazio. Allora, lo stato della ghiandola lacrimale principale è da studiare, però è da prendere relativamente in considerazione, perché la ghiandola lacrimale principale si può presentare ingrossata, si può presentare ecologica. Il fatto di effettuare una ecografia, adesso si chiama anche l'ecografia della ghiandola lacrimale, è sicuramente utile nel follow-up del paziente, ma non è assolutamente inutile. La biopsia delle ghiandole salivali invece rimane un presidio, per carità, sempre invasivo, però può dare delle informazioni che possono essere date anche da altri sicuramente da altre condizioni che meno invasive. Si arriva a fare la biopsia delle ghiandole lacrimali delle ghiandole salivali quando le informazioni che noi possiamo fornire al reumatologo sono senz'altro superiori.
Sul microbioma, se sono sufficienti i kit che noi troviamo per lo studio del microbioma intestinale oppure bisogna fare in realtà un esame dettagliato quindi si trovano i kit che ci permettono uno studio di microbioma intestinale se è attendibile.
Ci sono dei kit disponibili in commercio che sono validissimi, che ci consentono sia lo studio del microbiota oculare, quindi con un tampone congiuntivale riusciamo ad esaminarlo, sia lo studio del microbiota intestinale sistemico, quindi per eventuali addirittura nel futuro c'è la prospettiva di effettuare un trapianto di microbiota prelevato dalle lacrime. Quindi questo è veramente una cosa veristica, ma le basi ci sono per poter sviluppare.
C'è una prevalenza di batterica che favorisce l'occhio secco?
Assolutamente sì, devo dire che in una nostra recente pubblicazione abbiamo evidenziato dei cluster antigeni che sono più frequenti in condizioni di dry eye, che entrino nel determinismo del dry eye, che siano una conseguenza del dry eye che si ancora da definire, non è ben chiaro. Di sicuro ci orientano su come gestire la terapia.
please, Miss Conclusa. You treat your patient by yourself or you refer your patient to the nutritionist to have a special diets and special treatments of the microbiome.
Always we need cooperation, I think so.
La mia domanda era per Professor Giulia. Could you just tell me, please, in your opinion, which is the major cause for the atrophy of the meibomian glands in children? Is it the blue light screen?
I think it is very difficult to know the exact cause, and probably the screen and the less blinking for sure, because there is less blinking with accommodative work and screens, and also recurrent chalasia. They just occlude the meibomian glands, and so it creates also a lack of meibomian.
Sorry, just a question for Professor Giovanni. It's a personal question because lately I saw a lot of children with eosinophilia, with intestinal worms, and I realized it after a while because they seemed like allergic to them, and it was really hard to treat. And do you have any experience about it? What's your experience?
If I understand, it's with eosinophilia and also intestinal problems. With eosinophilia, for sure, because it's allergic, and so allergic just is commonly given dry eye. For the intestinal problems, I have no experience, so I can't tell you, but there is some disease, but very specific disease, some very rare eye disease that can, with intestinal problems initial, that cause this dry eye. So, for instance, there is a specific disease where there is abnormalities of the velocity of the intestine, and this is exactly the same on the conjunctiva, and this is why there is dry eye. So I can't tell you everything this way, but for sure there is some very unique rare eye disease caused by a problem with intestine.
So one thing that we're seeing in our clinic a lot more is aggressive vernal conjunctivitis in the pediatric population that's causing scarring in the meibomian glands. So why is that? Why are we seeing more allergy and more aggressive allergy? It could be COVID, it could be nutrition, more systemic inflammation than we've seen before. But if you're asking what's the number one thing I'm seeing in kids that is causing atrophy of meibomian glands, it's vernal keratoconjunctivitis.
I was talking about infestation, how it works.
Yeah, no, but I was talking, you were asking about atrophy of the meibomian glands.
No, there was only a comment. A teenager with meibomian gland atrophy asked for retinoids because some of them take the retinoids for the skin and they will produce the destruction for those glands.
Ok, chiudiamo la sessione, invitiamo qui i moderatori, il dottore Torchi, il dottore Vigo e il dottore Capparello.
Alla information and della. So thank you very much. Thank you very much and thank you very much. this kind of invitation. We're going to talk about inflammation and dry eye disease. Let's see if it works. This is my financial disclosure. And we recently published this paper, and for me it's an honor to talk about palate inflammation. Sorry. Thank you. To talk about palate inflammation in this setting, because palate inflammation, the idea of bringing palate inflammation to the ocular surface, to dry eye, I mean, started here in Italy by Stefano Barrettino and Maurizio Rolando. Palate inflammation is a protective immune response maintaining the ocular homeostasis that we need. And palate inflammation occurs when tissue experience a mild stress or damage that has not reached, now the inflammation status. In the presence of an intense or persistent chronicity of the stimuli, this regulatory mechanism will suffer, will become dysfunctional, from functional palate inflammation to dysfunctional palate inflammation, and if it's not enough, and if it continues, the patient will suffer from inflammation. Functional palate inflammation maintains homeostasis through a kind of different mechanisms. For example, increasing tear production, if there's one end, so we start producing more tears in order to protect our ocular surface, increasing blinking rate, increasing mucin secretion, because goblet cells are very important. Goblet cells, they produce THGB beta, and THGB-beta has an anti-inflammatory effect, as has been said by Sandra. And macrophages, they are also involved in this kind of palate inflammation. Of course, there's an increase of the epithelial turnover, and this compensatory system, if they fail, so we will pass to dysfunctional palate inflammation, and finally, dry eye and inflammatory. So in this cartoon, you can see the functional palate inflammation with a compensatory mechanism, and if it becomes dysfunctional, you can see that we will have more cytokine production, we will have an increased tear production, decreased tear linking, etc. So this is the concept of hormesis. Hormesis is important in order to maintain homeostasis. It's change, it moves palate inflammation to ocular surface, in this case, homeostasis. Hormesis and palate inflammation, they are not new. I mean, they are new for dry eye, they are new in the ocular surface science, but it's a concept, a very old concept of any of the fields of science. Of course, with time, with aging, chronicity, aging, also persistent external factors, low humidity, wind, comorbidities like autoimmune diseases that will move to inflammation. What's hormesis? The definition is an adaptive compensatory mechanism to moderate the stress and bringing it back to homeostasis. It's very active. It's not something that but the critical example is this one. For example, contact lens wearers. Contact lens wearers, contact lens, they are for the body, but the wearers, they use contact lens because they move from homeostasis to palate inflammation, but with time, what happens? With the use, with many use of, they misuse contact lenses, that will become dysfunctional and finally inflammatory, dry eye disease. And when these patients that they cannot tolerate contact lens, they decide to do something, they go to the surgery theater for LASIK, and that will destroy the ocular surface or whatever equilibrium was. This is a cartoon, but I want to tell about two other concepts, autophagy and inflammation. Autophagy is a key pathway in order to regulate and control damage of the ocular surface and adapt these cells to stress. It's useful to maintain homeostasis and prevent autophagy, deactivation of inflammasomes. And what are inflammasomes? Inflammasomes are something related to the innate immune. We are not talking about adaptive immunity. Adaptive immunity is related to inflammation, chronic inflammation, autoimmune inflammation. In this case, it's innate immunity. And it push the inflammatory cascades. They are related, because of time, I want to share with you this corticosteroid deficiency, cortisol deficiency is related to the passing from functional parainflammation to dysfunctional parainflammation. There are many works, but cortisol, it works keeping the immune response repressed down and helping the immune system to recover and moving back to homeostasis. The reduction of ocular surface cortisol levels promote the recruitment of inflammatory cells, mainly macrophages. There are some studies, one of these is this one. You can see that control patients, they have higher levels of cortisol in the ocular surface in comparison with patients with dry eye. And how can we address this? I mean, of course, we can treat inflammation, but in the future, we will have treatments to enhancers of autophagy, I mean, inhibitors of inflammasomes, scavengers of different oxidative stress, and of course, we can target and maintain parainflammation and decrease inflammation. Now, what can we prevent this? With low dose therapy. And there's a lot of clinical experience about this. Many papers coming from Italy. More studies. Addressing and showing us that parainflammation can be maintained with low dose of corticosteroids. As is being said by Sandra, I wrote the physiological low dose. That's great. That's what we need. And I want to pass here. This is from Typhus News 3. We have recently published that, and you can see that hydroflock in this case, uric plus hydrocortisone low dose can target the inflammatory pathway. And for finalizing, parainflammation represents a delicate balance between homeostasis and inflammation. The autophagy inflammasome axis plays a crucial role in this setting, and low-dose corticosteroids will be useful in preventing inflammation. And that's all. Thank you very much for your attention.
I was meant to be good at this by now. It's not working. It's not working. My disclosures today, I speak, consult, and do research for Bausch & Lomb. I am here today on my own behalf, not sponsored by Bausch & Lomb. Can I get back to my original slide? Okay, so red eye is one of the most distressing signs that our patients with dry eye experience, in part because it's interpreted in very negative ways. People that have red eyes are often interpreted to be staying up too late by their bosses, maybe using illegal substances. It might be interpreted as being emotional, but certainly it is not a sign of good health. And many of our patients will seek red eye solutions to help them see better. The over-the-counter products that are currently available target alpha adrenergic 1 and 2 receptors, which means that they often cut off the blood supply and the nutrition with the arterial side. What that means is patients will develop tachyphylaxis and rebound redness because that is an intolerant situation to the ocular surface, and the body will overcome the effect of the medication and begin backwards, and will begin to bring new blood vessels into that area. Lumify is a unique product because it targets the alpha 2 receptor at 1,000 to 1, so alpha 2 to alpha 1, 1,000 to 1, so it's very highly specific for the veins. It does not interfere with the delivery of oxygen and nutrition to the eye, which makes it uniquely positioned to be a safer alternative for our red eye patients. Can I come backwards again? It doesn't seem like it would be hard. Okay. I keep going forwards and backwards. Are you in charge or me? Am I in charge? It's not working. Okay, let's see about this. This is approved for children and adults over the age of 5. It was approved in the studies 4 times daily, although you'll see that it works very quickly within 1 minute and lasts up to 8 hours or longer. If anyone has used Lumify or Lumify, you'll see that it works very quickly. Again, within 60 seconds, you can see an effect, and this lasts at least 8 hours for patients. Oh, it's just, I got to take it. Okay. I'm not in charge. I am not in charge. Okay, here we are. Bosch has invested in research. We have a very robust data set for you, over 1,000 patients that we looked at, phase 1, 2, and 3 trials. You'll see at the bottom what we've recently had added to our armamentarium in the U.S. is a preservative-free formulation of this, which is exactly what we wanted for our patients. Now that's not coming to the Europe. I just spoke to the team before I came over on the plane. I hope that you get it one day. The Lumify Lumify formulation has a 0.01% of BAK. That's about half of what the FDA approves in the U.S. And again, from a clinician redness score, we saw that it did really well in the clinical trials. Patients also feel that it does extremely well. What you'll notice in this slide is that we did not see rebound redness. So even with continued and daily use, over 28 days, we did not see tachyphylaxis or rebound use here. The adverse event rate was very, very low. It was almost equivalent to the vehicle. The vehicle does have, again, 0.01% BAK. It does have glycerin and some other augmenting agents. So the irritation is very low. We did not see tachyphylaxis and very, very low rebound redness. Overall, it was very useful. It is very useful for our red eye patients, especially compared to the other products that we have available. And the preservative-free formulation is useful. Hopefully, I can smuggle some in for you all here in Europe.
Ci abbiamo una parola adesso al professor Giovanni Tedesco che ci parlerà del diet and diet.
All right, I gotta work this better than she did. So we're gonna be talking about diet. I'm gonna make a very bold statement before my slides come up. I've been doing dry eye for now over 25 years. I think that diet is 50% of the battle. So my book, The Toyo's Dry Eye Diet, everything that I'm going to be talking about today is covered in that book. I make no money from that book. All the money goes to free care. Just to see how far dry eye has gone, just a month ago, Forbes sent me a writer to interview me and talk about dry eye. So this is getting to be mainstream now. Forbes, a financial magazine, is writing about dry eye. Next slide. So why am I talking about diet? Because when I started the clinic 27 years ago, I started as 2 practices. One is ophthalmology, and the other is health and wellness. So on the health and wellness side, I had a massage therapist, a nutritionist. This is where I discovered IPL. So I've always been into this, and I've always thought that diet is important. Next slide. Okay, so this isn't a new concept, this is a very old concept. Hippocrates said that food is our medicine and medicine is our food. And what I think we should do as doctors is we should be prescribing food as medicine to our patients. What I've learned over the years, if you tell a patient just to eat better, they're not going to eat better. You have to sit there and specifically say, you need to eat this, this, and this. So I think you know the key terms, but microbiota, gut flora, and all metabolites is microbiome. But the thing here I want you to concentrate on, because I told the translators I go really slow. The thing I want you to concentrate on here is sirtuins. So there's a lot of information out there. It's under the title lifespan. We have these genes in our body that keep us healthy and also give us longevity. If you can eat foods and do things to stimulate those genes, you will live better, you will live healthier, you will have less inflammation. Those genes are called the sirtuins. You've got 7 sirtuin genes. There's also genes called foxogenes, and you've got about 4 of those genes. How many people here are doing cold baths or cold showers? Okay, the reason why you're doing that is you're stimulating the foxogenes so that you can live longer and healthier. How many people drink red wine because it thinks it's going to make them healthier? Right? Resveratrol. You're getting your resveratrol? That's stimulating the sirtuins. So we're going to be talking about STACs, sirtuin activating compounds. Okay, so what happens when we have a bad gut? So you have a lining in your gut that when you have good bacteria, that lining is solid. When you have a lot of bad bacteria, what happens is that lining in your gut starts to open up. Those tight junctions open up. It's bacteria, so when that bacteria is released in your body, what does your body think? It thinks it has an infection. So it releases all these immunological factors to attack this infection. That's why you have all this inflammation in your body. Bad gut, more inflammation, worse dry eye. So about 10 years ago, patients would come into my clinic and they'd say, I have dry eye, my eyes bother me, and I'd say, here, go get a stool sample. And they go, a stool sample? So what I was doing is I was trying to figure out, do they have bad gut bacteria? And lo and behold, all the dry eye patients that were coming into our clinic had bad gut bacteria. A lot of gram-positive. They didn't have all the good gut bacteria that you need to have those tight junctions. So that's when I said, we definitely have to start working on that. So, how many people here eat chicken or dairy or meat or eggs? That's all inflammatory. So every one of those things that I named. So when a patient comes in, I ask them, do you eat any of those? Because patients, when I say, how's your diet? They always go, oh, my diet's great, Dr. My diet's perfect. And I go, do you eat any of those things? They go, yeah. They're all inflammatory. All those foods are broken down in our body into arachidonic acid. Arachidonic acid is broken down into prostaglandins. Prostaglandins are made into inflammatory mediators in the body. So we really want to get away from that. So the foods that we're prescribing, I put them on a 2-month starter diet where we eliminate a lot of foods that they're eating, but we want them to eat foods that are prebiotic and probiotic. Prebiotic feeds the good gut bacteria. Probiotic is good gut bacteria. Now, how many doctors here are giving their patients probiotics? Okay. You stick a probiotic in an acidic gut, the acidic gut will kill them. I tell people it's like throwing a nerdy kid into a gang neighborhood. They just get beat up. So tell your patients to save their money until they get a good gut bacteria, and then a probiotic might work for them. So we want to eat foods that are low sensitivity and allergy. We want to eat foods that stimulate sirtuins, all foods that are anti-inflammatory. So after that 2-month starter diet, they can start eating and introducing one food at a time to see if they have an allergy to that food. Now, it's more of a sensitivity to that food. So, for example, I can't eat eggplant. Do I have an allergy? Do I get red? Do I get... No, but when I eat eggplant, my stomach doesn't feel right. I get bloated. So that's a sensitivity. So they'll start finding out which foods they're sensitive to. Okay, I'm not going to tell you everything. It's all in the book. Get the book. Eat more. So I'm just going to give you pearls. Eat more mushrooms. Why mushrooms? Mushrooms are prebiotic and probiotic. They're anti-inflammatory. They are a STAC, a sirtuin activating compound. And the best thing about them is 70% of dry eye patients have allergy. So you can't give them really allergy drops, allergy medications that are antihistamine. It's going to dry them out. So give them mushrooms. There was a big study comparing antihistamines to mushrooms in a study that was statistically looked at. And patients that ate the mushrooms did much better with their allergies than patients that took antihistamines. All right, now we're going to go into some of the sirtuin activating compounds. Blueberries. Pterostilbene is a sirtuin activating compound. Strawberries. Fisetin is a sirtuin activating compound. So you want to be eating these foods. Resveratrol. There's a big study in women. This is the best supplement to help them with dry eye. Resveratrol. It's the French paradox. Why do French women, they smoke, they don't exercise, they don't really care about their health, but what are they doing every day? They're drinking some red wine and getting some resveratrol. You don't have to drink alcohol to get your resveratrol. You can do it as a supplement. Big Harvard study showed that. Let me go back to the strawberries because my good friend Castillo was talking about autophagia. Senolytics go in your body when you eat senolytics, and they clean up the cells, the autophagic cells that you have in your body. So what happens is our cells are regenerating. But what happens to the waste? What happens to the cells that are dead and not working? You eat the senolytics, they're taken out. I didn't want to hear the gong, but I'm going to finish up here. Supplements. Actually, I'll talk about supplements when we get to IPL. There's NAD and CoQ10, so if you have any patients who are over 50 and you're doing IPL, you really should supplement with NAD and CoQ10. They're coenzymes that help your mitochondria. What happens after the age of 50? Your CoQ10 and then NAD go down. So if you really want to pump up your IPL efficiency, older patients should be supplementing with NAD and CoQ10. Those are coenzymes for the mitochondria. A lot of deficiencies. Now magnesium is a big deficiency, so you should consider supplementing your patients with magnesium. GLPs. Anybody here have patients that are taking Ozempic or any of the other, right? So it's actually, the Ozempic not only cuts down appetite, it's a glucagon-like peptide that helps with these patients who have diabetes, but a lot of patients are taking GLPs to decrease their obesity. We know with more obesity, you're going to have more dry eyes, so if they can get thinner, their dry eye is going to get better. But it turns out these GLPs are anti-inflammatory. So when you're giving them, they're actually decreasing. So we did a pilot study. Melissa runs our research department. We did a pilot study looking at patients that you took GLPs to see if their dry eye symptoms improved, and we showed that there was a 42% reduction in their symptoms. Thank you.
Un po' complicato il titolo. Allora, io parlerò, mi dice quando posso partire. Comunque parlo di un nuovo dispositivo che utilizzo da Lamezia allo studio, che si chiama ImmunoDx, che mi aiuta molto sia nella diagnosi che nel monitoraggio di alcune patologie.
verso qua.
Ok, questa è una definizione diciamo, di superficie oculare, quindi del film lacrimale e che la cornea insieme costituiscono il primo elemento refrattivo dell'occhio, quindi è fondamentale che il film lacrimale sia di qualità. L'occhio, diciamo, il film lacrimale ha la funzione appunto di lubrificare e di nutrire quello che è la superficie oculare, mantenendo una omostasi dell'occhio stesso. Allora, il film lacrimale, come sappiamo tutti, è costituito da 3 strati. Abbiamo lo strato lipidico più esterno, prodotto dal membo, dal secreto di mecomio, che proviene dall'evaporazione, poi abbiamo lo strato intermedio, lo strato acquoso, che è costituito dall'acqua prodotta dalla ghiandola lacrimale accessoria, che serve a idratare, nutrire e ripulire, diciamo, l'occhio stesso. E poi abbiamo lo strato più interno, che è il glicocalice, che è composto sia da mucine gelformanti secrete dalle global cells a livello congiuntivale e le mucine trasmembrane prodotte dalle cellule epiteliali, e questo strato serve a idratare, ha una funzione di barriere e a lubrificare l'occhio. Il fluido lacrimale è costituito da più di 2000 tipologie di proteine, 90 tipi di metabolite e diciamo, il suo contenuto riflette quello che è uno stato o fisiologico o patologico dell'occhio stesso. Con questo strumento siamo in grado di titolare, quindi non ci dà se è presente o meno quello che è il valore delle metalloproteinase 9, della linfotossina alfa, dell'IgE e sta uscendo anche la titolazione di nitroclorina 6, però attualmente io riesco a misurare il metalloproteinase 9, linfotossina alfa e IgE. Questa è la definizione di secondo, adesso è uscita la definizione del terzo al Congresso di Venezia 2024, per cui ormai l'occhio secco non è una sindrome, ma è una patologia vera e propria multifattoriale in cui la superficie oculare è caratterizzata dalla perdita dell'omostasi del film lacrimale e abbiamo dei sintomi oculari associate in cui abbiamo come fattori patogenetici l'ipersmolarità, l'infiammazione, il danno superficie oculare e le anomalie neurosensoriali. Da questo punto di vista è molto importante la funzione di barriera epiteliale, quindi un'alterazione della barriera mi innesca poi un problema di occhio secco. Infatti si è visto che la perdita delle giunzioni strette e anche una perdita sia delle cellule epiteliali che del global cell mi porta poi a una alterazione del microambiente e quindi diciamo che viene meno la funzione dei glicocalici che abbiamo visto prima. Quindi le metalloproteinasi, che sono degli enzimi proteolitici, innescano poi l'infiammazione e quindi sono dei fattori patogenetici importanti dell'innesco dell'occhio secco, perché crea poi un'alterazione appunto della funzione di barriera del glicocalice stesso. E qui riusciamo appunto a testare appunto le metalloproteinase 9, il valore cutoff è 38,6 nanogrammi per millilitro, valori inferiori corrispondono a una normalità, valori superiori invece sono indice di un'alterazione delle giunzioni strette oppure una perdita delle cellule epiteliali delle global cell. Più alto il valore e maggiore la severità poi dell'occhio secco, tant'è che riesco spesso a titolare anche valori molto alti fino a 1000. Quindi questo strumento ci permette a livello delle metalloproteinasi 9 di fare una diagnosi differenziale a livello di infiammazione dell'occhio, mi valuta anche la grande severità del danno dalla superficie oculare, mi guida nel trattamento, mi fa vedere anche se il trattamento è efficace, mi fa una diagnosi preoperatoria, mi riduce anche le complicazioni post-chirurgiche e mi migliora anche l'outcome post-chirurgico stesso. Allo stesso tempo poi noi possiamo andare a titolare l'IgE. Noi abbiamo due tipi di reazione allergica, il tipo 1 che è IgE mediato e il tipo 2 che invece è T-cell mediato. Nel tipo 1 abbiamo una risposta acuta a quello che è l'allergene, quindi noi come trattamento dobbiamo o eliminare l'allergene o dare stabilizzatori di membrana, utilizzare gli antistaminici o dei glucocorticoidi oppure delle molecole con doppia funzione, mentre al tipo 4 abbiamo invece una risposta ritardata, cioè male allergene, quindi utilizziamo immunosoppressori tipo ciclosporina o cortisonici. Quindi l'immunoglobulina E ci permette, il dato titolare, a far vedere che c'è una ipersensibilità di tipo 1 che appunto ha un ruolo patogenetico nelle congiuntivite allergiche. Il valore di normalità deve essere inferiore ai 28,08 unità per millilitro. Valori superiori sono appunto indici di un innesco della ipersensibilità tipo 1, quindi un'allergia. Quindi questo esame è importante perché noi abbiamo alcune volte dei dubbi che abbiamo una congiuntivite allergica o una congiuntivite magari virale, e con questo esame possiamo fare una diagnosi differenziale, ma anche spesso abbiamo occhi secchi che non riusciamo a differenziare da situazioni di allergia. Invece, per quanto riguarda la linfotossina alfa, si è visto che questo è molto importante perché soprattutto ci permette di distinguere una forma da deficit di global cells, quindi della componente mucinica, e poi mi fa vedere anche se c'è invece una iperattivazione delle T cells. Quindi permette di fare una diagnosi a occhio secco e anche di valutare il grado di severità dell'occhio secco stesso. I valori in questo caso di riferimento sono tra i 0,55 nanogrammi per millilitro e superiori ai 2,50 nanogrammi per millilitro. Valori inferiori a questo valore di cut-off è indice di un deficit di global cells, quindi noi andremo a trattare questa componente qui, che è sempre molto difficile da trattare chiaramente, mentre nella forma superiore ai 2,50 è indice di una iperattivazione delle T cells. In questo caso possiamo essere orientati a utilizzare la ciclosporina e in questo caso la prognosi è migliore per questi pazienti. Questi sono dei lavori che fanno vedere appunto i livelli di questa citochina nell'omosi delle mucose. Altro lavoro che fa vedere appunto che i valori bassi sono più difficili da trattare rispetto a valori più alti. Un altro lavoro appunto che fa vedere l'implicazione dell'infotossina alfa nella severità dell'occhio secco, e questo è il kit. Abbiamo appunto l'analizzatore, abbiamo dei test che sono diversi a seconda del mediatore che dobbiamo andare a studiare. Abbiamo un prelevatore di lacrime lo prelevo per capilloroscopia. Io lo faccio sempre alla da fessura e lo metto al lato esterno in modo da vedere appunto se è un prelievo consistente di lacrime, e poi si mette nel test card e si aggiunge 3 gocce di reagenti, che ogni reagente sarà diversa a seconda della titolazione che dobbiamo fare. Questo è come viene eseguito, bastano poche unità, 2.2 di lacrime. Questi sono i lavori scientifici di riferimento, e quindi questo è un nuovo strumento che mi orienta molto nella diagnosi, ma anche nel monitoraggio di pazienti. Sempre una metalla proteinasi molto alta mi indica magari di associare un trattamento con la luce pulsata. Vi ringrazio per l'attenzione.
Diamo la parola alla professoressa Alla, che ci parlerà della relazione tra il preferito.
Right, good afternoon, and thank you again for the invitation. Let me make sure it's working for me. Right, so the title rosacea blepharitis, it might not be the most accurate title, or maybe it does not exist. And the question, what's rosacea blepharitis? Because these 3 reports did not give it a name as rosacea blepharitis, give it different names. So maybe you can call it, if it's not working. That's it? Ocular rosacea, right? Let's try it. Or, yeah, this Italian way, right? Okay, good. Right, you might call it rosacea associated MGD, or you call it rosacea endotype, which is the DUS3 report classified as endotype leading to MGD, so part of MGD cause, etc. Right, so what is rosacea? This is a chronic inflammation on the face mainly, usually around the cheeks, nose. You see those flushed faces, cheeks, The hallmark is erythema, dilated vessels. There are triggers. Patient tell you with the heat, with the alcohol, with the stress, get worse. And the exact cause really is not known. What is it? What is this? Is it to do with the vascular hypersensitivity? Is it to do with the demodex? Is it to do with the genetic predisposition? Is it to do with the altered immune response? We don't know. But this is a nice consensus by the rosacea group 2019, and they said we got these forms how to diagnose it basically. He said either you got the form, those two forms on the face, the erythema, or you got the erythema on the face with the triggers, or two of those two things, which is one of them is ocular, telangiectasia, etc. So on that definition, if you just have a like rosacea, you believe it on the lid margin, might not be enough to diagnose it. But you'll see later that the definition has changed. Now, obviously, this is very stark, and this is important because if you want to talk about rosacea, ocular rosacea, you need to look about what the face looks like. And we jump to slit lamp, we tend to miss looking at the patient's face. But remember, this is just I'm going to run through some slides to show you. This is interfacial erythema. They might get more kind of inflamed. This guy got more edema around the nose. They might have some pustules, they might have, it could be inflamed, the female is the inflamed one. So sometimes a mixture of various manifestations, especially telangiectasia. When you look at the eyes, you can see from far the lid margin thickened, looks irregular and pink, and that's why I put zoom in picture, because I wanted to see zoom out. I wanted to see the face, the nose, what's going on. And this is how you come to it. And they're not uncommon, they come to you with blocked glands. Because with rosacea, blepharitis, call it for now, the main thing is this thickened lid margin, the telangiectasia, the blood vessels you see, and the blocked glands. So they tend to have a newborn grade 3, 4, or blocked completely. So, and just many more examples. You see the deformity of the lid margin is a severe case. The patients come to you and they really suffer with burning, stinging sensation, itchy. When you see itchy, look at the lid margin and you see those colored around the eyelashes. This is a demodex. And this is the sign you could ask them to look down, look at the eyelashes roots. So treatment for the skin, you don't need to worry much about it, but you tend to see that the pathology variation or not combination of treatment from topical to laser or IPL. And for eyes, well, basically, why it happened? Again, the same principle. It's if we believe in the same disease, it should be the same around the dysbiosis, the immune dysregulation, vascular hypersensitivity, or just genetic changes. Manifestation, don't underestimate that rosacea can lead to keratitis, sclerokeratitis. We've seen patients with corneal thinning, melting, perforation, so that is all rosacea related as well. So, not surprised, half patients of rosacea in their eyes, they don't know about it. And sometimes it's just the flushed face telling you the whole story. They walk and they sit up there and they see their cheeks really red, what's going on. And we know that demodex of rosacea. And this is figures like, if you have a rosacea on the face, 50% chance you have it on the eye. But if you have it on the eye, you still can have it in the face, only not. Because 20, and I'm still equal to up to 58% patients have it on the eye, but don't have it on the face, which is interesting. So, have it on the face give you a good clue, but does not mean it's excluded. How to diagnose rosacea in the eye? Simple. Well, they come to you complaining. It's a dry eye clinical picture. They tend to have a burning sensation more than anything else, irritation on the lid margin. They tend to be burning, lid burning, the eyeball is burning. That's common complaint. When you look at the margin, you see the sound, just about to show you a couple of pictures as well. Important to look at lipography, and we're going to talk about it in a second, and do the expression test. So there's a lot of focus now on the function, the libo, what it looks like, and what the gland looks like. Not the volume gland, how many drop out, what the gland's shape looks like. And this is another way with the International Rosacea Society. They said, okay, to diagnose rosacea in the eye, you can talk about one symptoms, one sign, maybe there is a facial as well. Right, you don't want to mix it with other conditions with a similar picture, like one of those here. Right, okay. So, It's very specific when you look at the lid margin, and I think always like, now if I ask you to look at a patient or sit down, you straight away pick up some signs. If you keep looking at the lid margin, you reach a stage where actually you can tell this is not normal and this is vessel are not what I expect. But usually there are those fine dilated vessels going around the glands. They sometimes can have clustering around the orifices of your main glands. And you see the glands are blocked, capped, and there's a gland inspisation as well. And this is the one thickened gland, you see so thickened margin, swollen. You can see here, to show you a lot of, if you see bottom right, this cluster of vessels, which is not normal to see in the margin. It's not the line, it's a bit of like a mesh of vessels. Okay, so mammography, this is very important. Now we can understand more about mammography because if you look at the upper eye, if someone comes to you and they have a normal lower eye mammography, you ask yourself, okay, why the upper lid have some change, not the lower lid? Now there's a lot of studies show correlation between upper eyelid and more systemic conditions, especially lupus, Sjogren, lymphoma, etc. But also in rosacea, a lot of changes happen on the upper eyelid, and the very early signs usually the glands become tortuous, like a weakly gland. But the study here showed that actually you have truncation, obliteration, they get fainter, like they call ghost glands. And this is not a good sign. That means actually the disease has been ongoing for a while. So this is just for another talk, but just about morphology of the glands, because it's not just about how much loss of the glands, 60%, it doesn't mean anything. What is the gland looks like? So we need to do a different way, and it's some project I'm working on now to look at different patterns of the glands, how correlate that with different diseases and so on. Right, this is one of my patients. You can see the bottom of the glands, they're fine, but they're hyper intense. So the signal, they call it signal intensity is high. But the top one, they start to become wiggly. This patient actually developed later very bad rosacea on the face and the eye, and struggling a lot. Now they're seeing multi-team because they're in further treatment. But just look at the upper eye. Now coming to management, we want to make it simple, right? So 3 things here to deal with. We know the hypothesis is over there. You have the lid margin, urinary glands issues, and you have the inflammation. You need to work on all 3 things. Demodex, you can see various treatment now. We now have the luxury with Zimri in the UK. We have ivermectin, which works well in my view. We've asked patients to have it at night time on lid margin, 6 to 3 months, 6 weeks to 3 months, and works very well. Obviously, IPL very important still, and it's interesting how now we know more about how IPL can kill the mites. This is some studies. I'm sure Roland will have also other views maybe. But also systemic therapies. I don't give them oral doxycycline unless they very low dose and we feel that this might be something make difference, trying something else. But I avoid oral treatment if possible. The topical treatments, there's azithromycin. In my hands, it doesn't work much. Erythromycin, old way, but it works. And anti-inflammatories, we talk about more on cyclosporins, etc. In office, obviously, you can do the exfoliation of the lid margin, which might help to reduce the biofilm. The expression very important with the IPL for the various benefits you know about it. Remember, those patients need to be seeing the pathologist, and often they don't know about it, and they surprise you, tell them, do you like to say, my skin doesn't like the sun? That's what they tell you that. When they put the bleach in the sun, they suffer. So this is a sign that this patient needs to address. And no surprise, they come to you with a dry. Now, something for maintenance, this patient is no cure. They're going to have a maintenance. So they might get better, but you have to tell them, look, lid hygiene is an ongoing thing. You have to use sun cream, you have to wear sunglasses, you have to do this and that. They have to really look after themselves. They have to reduce alcohol, exposure to stress. You can't work around it, but it's something very important. So just a summary here. What about low light therapy? Because a lot now talk about combination with IP and other things. I don't think it works very well for the telangiectasia, for the demodex. Yes, work as general, reduce the inflammation. Very good for those with a darker skin, but it does not beat IPL for sure. So IPL will be number 1 for that. Future is great because look at those just, I don't know if anyone uses niacinamide. Do you use it? Yes, I think we'll use it. It might help around the eye area. We don't use it. Probably experimental so far. think about mind-skin-eye axis, because very, very linked between rosacea and stress and anxiety. So those patients need some support, that's important. And some studies showed increased density of dendritic cells in the cornea. So maybe IBCM will become a tool in future to diagnose rosacea in the eye or anything else. And also help you manage if IPA working for those. Doing microbiome, you understand more and more. So the more you understand what's the microbiome, the profile there, you can target your treatment, can use topical antibiotics, wipes, etc. And the last couple of things is about fluorescent angiography. Actually, if you can see the vessels and you can see IPL, get rid of them, that tells you whether IPL working or not. If not working, you can titrate it. So we can have a way to monitor what we're doing and tailor treatment. This is my saying, this is not anyone else saying. To fix the lid, you must respect the skin, calm the nerves, and modulate the glands. And I think this is a key thing here, because it's not just about the skin and the eye here. And I finish with the last slide. This is a Dewey's report on the rosacea. And it's very clear to tell you this is kind of an endotype of vesicular cell disease, not a disease on its own. For diagnostic, which we mentioned earlier, but the focus on the telangiectasia, on what the patterns of medullary glands and inflammatory status. Biomarkers are very useful here, especially the L27 and the treatment is combination of treatment, obviously, but remember you need to target the modex, you need to try the gland dysfunction. And the cautious here, which is, we've been telling patients for the last many years, stop using those heat compresses on your eyelid when you have rosacea. It's a common mistake given by Muslim practitioners. Okay, just use a heat mask and massage. This is like what actually it is not. It have to be personalized treatment. They might need it, but in just a modified way. So I'll stop here. Thank you very much. And I'm going to run the slides.
Any question on Benitez de Castillo?
Thank you, Samir. I think regarding with Samir's presentation, I think that we as ocular surface specialists, we should know a little bit about dermatology. Why? Because, for example, you have seborrheic dermatitis, rosacea, atopic dermatitis, irritant and allergic contact dermatitis. All of them could produce eyelid eczema. And if we treat them differently, because they have different treatments, we can improve ocular surface. So we should work, we can work with dermatologists, or at least know a little bit about dermatology.
Absolutely. Yeah, we treat rosacea and it's topical ivermectin. We use IPL and laser to really try to nail that in. We also have a bracelet for those redness products.
The one thing that was very interesting what you said is, I get so many patients that say, I don't have rosacea, because when they think of rosacea, they think of what's on the nose, what's on the face, but we can see it. When we see those telangiectasias, we see that they have blood vessels. Now the one thing is, they have a thicker epidermis. So I have patients of all skin types that have rosacea, but they don't think they have rosacea because their skin type is so thick. Their epidermis is thick. Same with young people. So up until the age of 28, your epidermis is, your fibroblasts are making collagen and elastin to make a thicker epidermis. But then as you get older, your epidermis starts to get thinner and thinner, and then you start to see those blood vessels. So patients will come in and say, I didn't have this when I was 20, I didn't have this when I was 30, I didn't have this when, yes you did. You had it all those years, it's just your epidermis was thicker. Actually, I have a question for Melissa, because you didn't mention it. So after IPL, we use Lumify, and why do we do that?
Right, so one of my hacks has been to use Lumify not only for the eyes, but also to basically clean out the face to give people some type of reduction of redness. Instead, I think there are several products that are out in the market that are very similar, but we create our own solutions for these already, and it helps them while they're waiting for IPLs to kick in or laser.
I'll ask you a question, but for the rosacea is to say, I think patients would like to say share. The thing is that stigma that I'm looking at me now, right? Especially ladies who like it. But we have to tell them they have. My question about management of red eyes. People come to us asking for Lumify, don't have in the UK, they go it online, they get it. They love it, Lumify works for them. But I always worry about long-term. I asked you earlier, what do you want long-term use? Because now, if you practice dry eye, you can see those patients coming with dry eye and with red eye, you don't like it. So I think it's another area we're going to work out in the future, how to manage red eyes. So, what's your experience for long-term?
Yeah, so we did a quick study on Lumify when it first came out, and because it has glycerin in it, people's tear breakup times went up, but they did have some dryness, and I think probably everyone who's tried this will notice a little bit of dryness, and you have the surface area, so it does stretch the tear film. I tell my patients to use it sparingly. This is not something to be used every day, it's not medicinal, it's not therapeutic. It helps, if you're trying to go into a like meeting with red eyes, but it's not for every day.
So one of the things that you brought up in your lecture, which is really interesting to us, is the cortisol levels. So one thing that we did with really severe red eye patients is we used ACTH, an injectable that increases the cortisol levels in the body naturally without taking it orally, and that decreased red eye. So if there's some correlation between cortisol levels and the eye, that's interesting, because maybe these injectables are the thing.
Have you assessed this? I mean, after injection and look at the cortisol levels.
No. As soon as you said it, we looked at each other and said we need to look at this. But yeah, endogenous, and this goes with the diet and everything else. Systemic inflammation will cause dry eye. Systemic inflammation will cause red eye. So if we can lower systemic inflammation, so the way I do it is I first try to do it with diet. If that doesn't do it, then I do low-dose naltrexone. And then if that doesn't do it, then I do injectable ACTH. So it's a stepwise fashion into trying to lower inflammatory mediators in the body.
Totally, because I think we are not legs, eyes, and whatever, gut. I think we are only one, and also all these organs are related with, brain inflammation. And this is related with depression and anxiety. And this is very important because patients with dry eye, they have anxiety, they have depression, they have stress, and because of this, they have no inflammation, and they have the pain threshold goes down. So if this, the pain threshold goes down, they will suffer more, they will complain more, and they will have more anxiety and depression. So we are only one. We have to treat the patient. Holistically.
We're a ophthalmologist, a dermatologist, a psychiatrist, an immunologist, a rheumatologist, a pediatrician. We're everything.
Okay, thank you for the. I'm looking for my copy of the book, by the way, so thank you. No, someone looked at your book and told me this is not personalized treatment. This is a food for the health, for the dry, which is true. And they talk about actually you need more personalized treatment because not all of us have the same food with the same response. And this is where you heard about nutrigenetics now. With eyes, they write genetic testing because what works for you, if I give you vitamin B, might not work for the same one, I give vitamin B. And that's also highlight that you don't have to have deficiency of anything of those vitamin supplements that you take. You could have a normal level, but it's still really not absorbed or doesn't act on a cellular level. So what's your opinion?
Yeah, so what I try to do with the book is, if somebody's allergic to blueberries or something, I try to give them a substitute of what they're eating, but it's very specific. What I found is you can't be general with the patients. So if I just tell them, oh, you can eat well, this is not going to work. So really specific, and then they can come back to me and go, well, I can't eat this. So if you can't eat artichoke, let's do asparagus. If you can't do blueberries, let's do strawberries. Just, again, you can sit down with a patient and figure out. But you have to have a very restricted diet to find out what foods they're sensitive to. So there's a lot of patients that are sensitive, like we just had a patient that came in that has a mast cell activation syndrome. So I have to eliminate all the foods that activate mast cells. So that starts eliminating things in their diet, so I have to replace them.
So we say, do you do some workout before you advise on nutrition, like genetics test, some skills test, etc., or vice versa? You start your general advice and then you might tweak it along the way if you're not responding, try to respond.
Yeah, I think the future is going to be everything that we saw today with what the Dr. Tedesco, taking a little bit of the tear sample, measuring that, doing a genetic test. So I used to have our patients do 23andMe, so I can figure out what susceptibilities that they have. So we now know with lifespan technology that it's 30% genetic and 70% environment. So we used to think differently. We used to think your genetics are your genetics. You have rosacea, and that's it. You got rosacea, and it's going to affect you your whole entire life. But we now know there's things that will aggravate the rosacea. What was interesting to me is a new study came out, because we've been talking about this, that since COVID, our patients are getting crazier. Like they're mentally, it's different. It's different now than it was 5 years ago. And now they're finding with long COVID, those patients, if they look at their gut bacteria, they have really bad gut bacteria. So you have COVID and bad gut bacteria, then you have more severe rheumatoid arthritis, more severe gastritis, more severe depression, more severe anxiety, all those things. So I really do think COVID has kind of changed the immune system a little bit in some of our patients, and we have to be aware of that. So now I'm asking patients, did you have COVID? Have you had the vaccine? How many vaccines did you have? How many times did you get COVID? Do you have long COVID? Did it last a very long time? Or was it just 3 days and then you were over it? So I think the future is we're going to get a blood test, we're going to get a stool sample, we're going to get a tear sample, and we're going to be very specialized. So that's concierge medicine. I don't know if we can do that. The time, that's going to take a long time. So the practices that can be more concierge and do that are going to be the practices that are going to really attack dry eye and attack it well.
Amazingly, very interesting. I'm using the technique, say you, I can't remember the name of the industry, the company that owns it, but I think it's very important to perform in patients with dry eye allergic studies, because they are mixed. They are not two separate conditions, they are mixed together also with pollution, and that's what a long time ago, Andrea Donati, he wrote a paper on urban dry eye, or urban whatever, but it's important.
Well, actually, we sometimes give them antihistamine drugs, even though they don't necessarily have allergic disease, and they get better. I don't know from experience.
I have a question for the
The DREAM study showed that there's no relationship between the substitution of omega-3 and dry eye, but I was really, really surprised when I heard that result.
So Penny Aswell and I are friends, so let me just say that. But I told Penny, you took olive oil as your oil and omega-3, and they both work. So she should have picked an oil that doesn't help dry eye disease. So yeah, like bad oil. Like if she would have picked bad oil or something different. So she's getting good data from the DREAM study, looking back at it, but I don't think you should make the conclusion that omega-3s don't work for dry eye. Omega-3, out of all of the supplements, is the most studied supplement. So if you go to PubMed and you put in omega-3, you will get 1 million research articles saying it's good for you. So I put my patients on omega-3. I think that's the first. If I were going to say, because some patients don't want to start out with 7 supplements, for women, I start them off with an omega-3 and resveratrol. For people over the age of 50, CoQ10 and NAD. So don't give them don't give it all at once. You could start going 1, 2, 3, 4, and then work your way. But that's where the studies come in. You know, get a magnesium study. B12, our absorption of B12 decreases as we get older. And the reason is our intrinsic factor in our gut isn't working correctly. So when patients are taking B12 orally, it's not being absorbed. So they need to either do it sublingually or injection. So as they get older, that's another one to get. But we could do studies on all of these vitamin deficiencies. But
Yes, thank you. Another question. What about practicing sports in the global management in dry eye?
Sports and dry eye?
Sport and dry eye.
Well, so here's something that we're looking at is video of activities. So in baseball players, baseball's not a European game, but baseball players have to stare at a pitcher. Let's say cricket or baseball. They have to stare, you know, they're sitting there and they have to stare at that ball coming in, or a tennis player. So the longer they're staring, their tear film is breaking down. So you're seeing a lot of athletes that are having problems. I don't know about soccer, if goalies have the same problem because they're sitting there, but they're not blinking enough. So we have a lot of athletes that are coming in saying they have dry eye problems. A lot of kids who are playing video games and just sitting there all day long playing video games who have dry eye problems. So our biggest gain in dry eye patients is 10 to 30, and it's all because of either sports, video games, Netflix. 2 of our 3 daughters have dry eye. Why? They're sitting like this, Netflix all day, Snapchat, everything. So this is becoming a global problem. That's why more people are talking about it.
The other side of my question, we can treat a dry eye by practicing sports. It's the question.
Instead of depression, it increased the pain response. So,
yeah, no, it's a lifestyle changes, you know, in terms of endorphins being expressed with sports. So runner's high, all those things. So getting them off the couch, getting them not playing video games, getting them not on the phone. They're nutritionally better if they're playing sports. All those things are important. Did you want to?
Sorry. Stop question.